And on behalf of the Alzheimer's Association and Isaac Health, welcome to the Empowered Caregiver. This is a four-part series. All of these sessions will be recorded, and all registrants will receive access to the recording, a copy of the presentation, and the handouts following each live session. You will be in view and listen mode only if you're joining us live. The chat and QA features are open. Please drop in questions or comments at any time. We will have QA following the program. At this point, I would like to welcome Dr. David Fisher, retired, an Alzheimer's Association community educator. He will be facilitating our session this evening. David, I am turning it over to you.
All right, thank you, Courtney. It's my pleasure to also welcome each of you to the first session of this four-part series on the Empowered Caregiver. The series is focused on those who are caring for and dealing with someone with Alzheimer's disease. We will start today by spending some time sharing with you an understanding of what Alzheimer's disease is and how it changes over time. You will get to hear some statistics about how this is a large and growing international concern, as well as some of the latest science behind our knowledge of the disease. From there, we will discuss how caregivers can build the foundations of caring and support. We'll learn some important tools that caregivers will need for themselves as well as for their loved one. We will share some tips on how to make the changing relationship between caregiver and loved one less stressful and more successful. And perhaps most important, at least in my mind, provide ideas for how to help the caregiver care for themselves. Now, I think it's time to introduce our speaker for today, Dr. Joel Salinas. Dr. Salinas is the founder and chief medical officer of Isaac Health, an online brain health clinic specializing in interdisciplinary care for people with Alzheimer's disease and related dementias. He is a fellow of the American Academy of Neurology with additional training in behavioral neurology. He helps lead the American Academy of Neurology's National Brain Health Initiative and has conducted NIH-funded research on the psychosocial determinants of health, promoting cognitive well-being at a population level. He's authored over 50 peer-reviewed academic papers, contributed to 8 books on evidence-based neurology. He is currently a clinical associate professor of neurology at NYU Grossman School of Medicine and was previously on the faculty at Harvard Medical School and Massachusetts General Hospital, where he also served as the clinical director of the McCants Center for Brain Health. I promise you that today, listening to Dr. Salinas will be time well spent. So let me get out of the way and pass the baton to Dr. Joel Salinas.
Thank you so much. I'm really pleased to be here. I'm excited to share a little bit today about the foundations of caregiving. But first, I always like to maybe do a little bit of level setting around understanding what dementia is. And of course, throughout today's presentation, if questions come up, feel free to enter them into the Q&A section on your window there, and then we'll be able to address them at the end of the talk. So just to provide a little bit of context, so in the US, the aging population is one of the fastest growing groups out there. By 2050, the older adult population expected to double. And we see year to year that even people over age 90 is going to increase. However, there's no guarantee that those who've lived longer will be healthier. And just to give you a sense of, how people are affected by conditions like Alzheimer's disease, I wanted to share just a slide with an example of a few famous people who have had Alzheimer's disease. You can see here Ralph Waldo Emerson, Ronald Reagan, Perry Como, Dear Abby, quite a few people. See if you recognize any of them. And the truth is, Alzheimer's disease is a problem because it affects everybody. Right now, nearly 7 million Americans are living with Alzheimer's, and by 2050, that number is expected to rise to nearly 13 million. And you can see here that out of all of the different causes of deaths in the US between 2000 and 2017, many other conditions like prostate cancer, heart disease, and stroke, those numbers have gone down, but Alzheimer's disease is that cause of death that has really increased quite dramatically by 145%. 1 in 3 older adults will likely develop Alzheimer's disease or some other form of dementia. And we know that over 11 million Americans provide unpaid care for people with Alzheimer's disease and other dementias. And just to address a question that comes up often is, what is the difference between the phrase Alzheimer's disease and the word dementia? Well, dementia is an umbrella term that usually describes a total range of symptoms associated with cognitive issues, memory or thinking issues. By definition, dementia is the loss of memory or other thinking function due to changes in the brain. It usually is bad enough that it interferes with daily activities, and Alzheimer's disease is the most common cause of dementia. But oftentimes, people can develop more than one cause. We call this a mixed dementia. And many memory disorders are reversible and not truly dementia. There's also a continuum of Alzheimer's disease. I think it's helpful to think of a continuum, which is that at one end of that continuum is your normal, typical day to day thinking, and everybody has their own normal. This is when somebody doesn't really have any symptoms. But if you begin to notice changes in your memory or thinking, and they're not really interfering with your day to day functioning, that would be called mild cognitive impairment. Oftentimes, people will abbreviate it as MCI. Once those issues progress to the point where they really do interfere with your activities of daily living, then that's called dementia. And dementia gets broken down into three stages: mild, moderate, and severe. The more severe the dementia, the more your daily activities are impacted, until at the severe level, pretty much all of your activities of daily living, you're dependent on others to help you out with. Uh, why is it important to address these issues as early as possible and to see a doctor? Well, one of the things that has really been developing a lot in the field is access to available treatments. I'll mention this in a little bit, but there's been some really historic changes in the treatments for these conditions, where we're actually able to not just target the symptoms of Alzheimer's disease, but we're actually able to target the biology of Alzheimer's disease, the disease itself. But it's most effective at the earliest stages of the condition. And I think it's true of all these conditions that the earlier you're able to detect and diagnose, the greater the impact of anything that you do over the long term trajectory of these conditions. And includes early on building a care team, participating in support services, getting a lot of financial and legal arrangements done, having an opportunity to potentially participate in clinical studies, and addressing any safety issues before the safety issues become a problem. There's a lot of ways to detect these conditions earlier on. Sometimes you may have heard of a term called biomarkers. These are also known as biological markers. Really, they're just measures that really let us know the presence or absence or the degree of disease that's going on the brain itself. And it's a tool to help us detect disease. And it can help us with determining the type of dementia or cognitive impairment that somebody has. And it's important for both research studies, but also within the clinic. One example of this that many of you may be familiar with is an MRI, which helps us really to see changes going on in the brain. And you can see in this image here three different brain scans of a person at different stages of the disease. The cognitively unimpaired stage here means that they're not having any symptoms of memory thinking, and you can see how the folds between the brain looks pretty full all throughout. But as the disease progresses, going into the mild cognitive impairment stage where somebody has symptoms but don't necessarily have impairment of their day-to-day functioning, you can see those folds between the tissue of the brain here seem a little bit more obvious, these dark spaces here, which shows that there's a little bit of thinning going on in the brain as the disease starts to progress. And then once somebody has developed Alzheimer's disease dementia, when they're really having interference, you can see that those folds here are a lot more prominent. And in particular, the hippocampus, this little area here nestled in the brain. And just to orient you here, this is the right side of the body, this is the left side of the body, and it's like you're kind of being faced by the person here. You can see that the hippocampus, which is really critical for memory, becomes thinner and thinner, so there's more space there. And that really is a product of the disease and of abnormalities beginning to cause injury and leading to the brain to start to thin or shrink almost. We also have new types of brain imaging called PET scans. These PET scans involve injecting a special molecule into the bloodstream that attaches itself to the specific types of biological changes of the disease. The most common here is amyloid. Amyloid, especially more specifically called amyloid beta, is one of the things that really underpins the disease. And you can see over time, from cognitively unimpaired to Alzheimer's disease, the buildup of all the amyloid plaque continues to go up and up and up, and you see it becomes brighter. Same thing on the PET scan where they're targeting another really important protein, tau, from someone who has no symptoms and is doing fine. Over time, they get a buildup of the tau protein. And both of these together are really the enemy when it comes to Alzheimer's disease. In that continuum of Alzheimer's disease that I mentioned, over time, as the disease progresses, you have a decrease in memory and thinking function, and you start to decline into mild cognitive impairment and dementia. You may have signs of the disease before, on the brain itself, before you even have symptoms. And it's important to distinguish this from normal or typical aging, where you may have some decline, but it's never so severe that it amounts to the level of a mild cognitive impairment or a dementia. The timing of when Alzheimer's disease should be treated is something that is still being studied across many different clinical trials and other forms of research. But the key thing here, just to kind of show you, is that as the biology of Alzheimer's disease kind of builds up, you start to get worse and worse functioning. But the truth is that you can sometimes have a buildup of these abnormal proteins and other changes going on in biomarkers like the MRI scan, maybe 10 or even 20 years before you develop symptoms. And so researchers really trying to figure out how early in the disease process can we target these things, because that's when we're most likely to see a pretty substantial benefit. And just to show you a map here of the drug development pipeline, there is so much research going on right now. This is one of the most exciting times for the field of Alzheimer's disease and other dementias because there's been so many emerging developments. There's 164 clinical trials that are active right now, assessing 127 different drugs at various stages. Phase 3 is the one where we're really looking at the potential for impact on disease as well as on symptoms. But I'll just say that there's a lot happening in the field now. And this is a really, really powerful time to not only contribute to research, but to also to really be proactive about managing these things, because there's a likelihood that there may be a treatment, if not today, tomorrow. So with that said, I'll now pivot to talking about how to build the foundations of caregiving. So in this module, I explain the relationship, how relationships change over time while someone is a caregiver. I'll describe different elements of what's called the person-centered care approach. We'll talk about identifying possible members of your own caregiving support team, and we'll also talk about some very specific action steps that can help to lower caregiver stress. So who's considered a caregiver? A caregiver is really helping a family member or friend. And that's something that people often do without actually calling themselves a caregiver. But if you give your time to help a person living with dementia, you are a member of the person's care team. That means that you are a caregiver. You're not alone if you do not have any training to be a caregiver, and it's common to feel a little unprepared. The good news is that there are ways that you can empower yourself to take control of your caregiving role and live well as a caregiver. With the right help and support, you can give good quality care while still taking care of your own well-being. And this is really important because taking care of yourself can lead to a better experience for both you and the person living with dementia. What do caregivers really do? What does this caregiving role involve? Caregivers help with activities of daily living like eating, using the toilet, or getting dressed, and also providing emotional support. But they can also take on tasks like managing the person's money, making doctor's appointments, helping with transportation, and a whole lot more. And there are many things that we do every day without even realizing that we are caregiving. You are part of a large group of people in the US caring for people living with Alzheimer's or another form of dementia. As I mentioned earlier, there's more than 11 million Americans who are providing unpaid care to more than 6 or 7 million people living with Alzheimer's or other forms of dementia. Family members, friends, or other unpaid caregivers provide the majority of the help to older adults in the US. And family members can have different caregiver roles. Some may even help from far away. Although 64% of caregivers across all age groups say that caregiving is stressful, it's nice to know that about 92% say that it's also rewarding. All caregivers have their own special challenges depending on their situations. However, there are also some common experiences that caregivers share, and by knowing what these are, you can feel a little bit more prepared for what might be ahead. As the disease progresses and the person's cognitive abilities decline, you may experience changes in your roles and responsibilities. You may find yourself taking on new roles as the person you care for may no longer be able to do certain tasks. For example, they may have trouble putting away the dishes or folding the laundry. They may also have trouble with more serious responsibilities like paying bills, managing money, and even legal matters. So, what can you do? It's helpful to have honest conversations about the future and put plans in place soon after receiving the diagnosis. Always include the person living with dementia as part of the conversation whenever possible. And one of the things that I like to emphasize as providers here at Isaac Health is that when we give a diagnosis, we know that we're not just giving a diagnosis to the patient, we're giving a diagnosis to the whole family. This really changes a person's life. And what I would say is that having these conversations about planning for the future can feel very awkward earlier on, but it's important to have them early while people can participate in those conversations. I often say that if the conversation is no longer awkward, it might be a little too late because you really want to have these conversations early. And this will allow your loved one to have a voice and help you better understand what they want, and you'll feel better prepared to take on new roles and be more confident in making decisions for them when they're no longer able to participate. There may also be some changes in your relationship with family and friends. Some social isolation is common among caregivers, and when you find that you have less time for your family and friends, you might also find them pulling back a little. They may not want to spend time with you and the person living with Alzheimer's because they're afraid to do or say the wrong thing. They might not understand that the disease is causing the person's behavior changes, or they simply might not believe or accept that the person has the disease. So, what can you do in these situations? First, I would just say reach out. Let them know that even though Alzheimer's has changed some parts of your life, you still value their friendship and support. Really include the person living with disease in these conversations as well, whenever possible. Consider inviting a few friends or family members over, depending on how the person with Alzheimer's is feeling that day. Educate them about the disease. Be sure to let them know in advance of any physical or emotional changes they may notice in the person living with dementia, especially if it's been a while since they've seen the person. You can offer them tips about the best way to communicate with the person. So, for example, in the early stage, you might say, Mom or my wife is still able to share her feelings, needs, and desires, but she may need a little bit of extra time to answer your questions. Or if the person is further along in the disease, you could say, Mom or my wife's ability to communicate is a bit more limited, but she would still like to be involved in conversations. If you can ask her yes or no questions, it helps her feel more included. You could also give your guests ideas of activities they could do with the person during the visit. All these suggestions can help them to feel more prepared. Another change you may notice is changes in intimacy. This is an awkward topic usually, but I think it's an important one. As the disease progresses, you may not be able to have the same emotional or physical intimacy you once shared with a person living with dementia. You may feel a lot of sadness over these changes, but know that you are not being selfish if you have these feelings. It's very normal. It's also typical for people living with Alzheimer's disease to have a change in their sexual drive. Depression, physical illness, and even some medications can cause a reduced interest in sex. It's also common for caregivers to lose sexual desire. This happens sometimes because caregivers can be physically and emotionally exhausted. It can also happen because your role has changed from being an intimate partner to being a caregiver. So, losing sexual desire can also come from the changes you see in the partner's personality due to the progression of the disease. So, there are, there are things that you can do. Absolutely. Do not feel guilty if your sexual attraction to your partner changes. You can find new ways to connect and stay intimate with the person living with dementia as the disease progresses. So, here are some ideas. You can play the person's favorite music and listen together. You can practice romantic, non sexual touching, such as holding hands or hugging. You can do an activity that you both enjoy, like cooking or going to a museum. You can go for a walk together. You can talk about favorite memories from the past. And you can even pray together. or simply talk about your day and spend some time together. Just keep in mind that these changes are very normal, and talking with others who may be experiencing those types of changes can be helpful. So consider joining a support group so you can connect with other caregivers and share and work through your feelings and get that support that you really need. Now, let's move on to discuss the person centered approach to care. You may have heard of a person centered kind of care approach, but what exactly is this? Person centered care focuses on the individual first, and then the care is built all around their specific needs. It involves using what you know about the person, including their likes, dislikes, interests, and their abilities to give the best possible care. There are a number of benefits to using a person centered care approach for both the person living with dementia and the caregiver. For the person living with the disease, some of the benefits may include fewer dementia related behaviors, which may lower the need for medication to treat these symptoms. There's also the benefit of less boredom and feelings of helplessness. It can also lead to lower levels of agitation or irritability, and potentially even an increase in happiness and a sense of well being. So, here's how the person centered approach can help you as a caregiver. It can increase your confidence in how to address dementia related communication and behavior changes. It can increase your satisfaction in being a caregiver. It can improve your relationship with the person with the disease, and it can provide a better quality of life for you and the person in your care. There are 5 strategies to person centered care that can be helpful. These are just kind of tips and some advice that you may find helpful. The first is use your knowledge of the person. Consider what makes the person unique. This can include really understanding their values, their beliefs, interests, abilities, their likes and dislikes. So, for example, if they love music, try to incorporate music. If they love to be outside, try to incorporate elements of being outside. If they like feeling comfortable, think about clothing that makes them feel comfortable or textures that are really comforting, like a quilt or some other kind of fluffy blanket. Keep in mind that their hobbies or interests may change over time, and it's helpful to pay attention to that. Maybe they really like painting, maybe they like crafts, maybe they like puzzles, maybe they like playing card games, maybe they just like reading or kind of looking at movies or shows on TV. Talk to others who are close to this person living with dementia if you don't know them well enough, because it can really help to give you some clues about what kinds of activities and things can really brighten them up and really kind of connect with them. The second is to connect in the moment. So try seeing the world through their eyes. This can really help you to understand their feelings. Sometimes it's just a matter of just taking a pause, taking a deep breath, and really just visualizing what the day to day life can really feel like for them. What does it look like? What are they smelling? What are they feeling? What are they hearing? What thoughts might they have? What feelings might be going through them? And that can begin to open up your curiosity about what their perspective is and what might be why they are upset or triggered by certain things and why they might be really appreciative for others. Really, as best as possible, see and accept the reality because it may be very, very different from yours. And as the disease progresses, the more you focus on feelings and not facts, the better off you'll be. Just really understanding kind of the positive feelings, the negative feelings, and even neutral feelings of calm. If a topic bothers or upsets them, you can always switch to a different one. And it can also help to kind of keep a log of what types of topics can make them feel really bright and what types of topics can upset them. The third tip is to help make activities meaningful. So make sure that the activity that you're engaging in has meaning and purpose for the person. Take into account that the person's abilities, interests, likes, and dislikes. So some examples there can include finding activities that involve creating things. So, for example, if they want to feel really productive. Maybe that involves creating kind of holiday cards or creating letters for others. Maybe if they like the idea of engaging in kind of building things that's important, so you can incorporate kind of some building materials that can include even things like Legos. It can include blocks, or it can include some really really basic kind of construction of things, really understanding kind of these kind of interests, likes and dislikes, and sometimes having a good appreciation for what somebody did their whole life can also help. If somebody has been a physician their whole life, it can be really helpful to put them in situations where they talk about kind of the body and health and disease. If somebody was a caretaker their whole life, it can be helpful to put them in situations where they can feel that they're caring for someone else, whether that's a pet or a child, or even just kind of putting them around other people where you kind of give them a little bit of a responsibility or making sure that things are running smoothly. Give them choices. This helps the person feel really respected and can be really successful, and know that the person can feel joy, comfort, and meaning even when the dementia is advanced. Really remembering that they are still there, and these feelings can still really come up. And if you can catch and really pay attention to when these feelings come up, that can help give you information about what activities are most meaningful. And sometimes it just be helpful to go with the flow. You don't need to plan every single activity ahead of time. And it can be important to know that as the disease progresses, you may need to adjust activities. You may need to bring in some accommodations. There can be an opportunity there to really learn kind of who this new version of this loved one is each day as the disease changes. It can open up some capabilities, it can also decrease some capabilities, but always thinking about how we can help them kind of be at their best, regardless of what those capabilities are. I had a patient who was a musician who played the piano, and he was really scared about losing his ability to play the piano, because he used to play very complicated pieces and beautiful kind of concertos, and he used to play to big rooms. And as the disease progressed, it became harder and harder for him to play these very complex pieces. But one of the things that he found really meaningful, and his wife as well, was really helping to consider that sometimes we do want to change the complexity of those pieces, because playing at his top level is going to change over time. But at the same time, he's still playing a piano to some degree. He's still kind of livening up the room and helping to engage people, even if his new level of playing is changed. So whatever you can do to make these activities meaningful will really be powerful in terms of the impact that it can have on quality of life. The next strategy is focusing on supportive relationships. Think about choice and flexibility instead of how much you can do in a day. We can often put ourselves under a lot of pressure to be perfect at everything all of the time, and that can cause a lot of stress. So, the more you can build in flexibility about what you can do and accomplish in a day, I think the easier it'll be to manage when things don't work out as planned. Pay attention to what's happening with the person in any certain moment, because that can also give you certain cues. And encourage independence. Do activities with them rather than for them. One of the things that I find really important when we're working with patients and families is to give some reassurance that our job is not to take away independence. Our job is to help to preserve the independence as much as possible. So whatever it is that you're able to do on your own, we want to help to kind of maintain that as long as you are finding it enjoyable. If you are still able to do things like cook, even if it's at a simple level, we don't want to take away those activities if you find meaning in them. Sure, the complexity of the meals may not be as complex as a big Thanksgiving dinner, but at least being able to engage in making some salad, some pasta, making some sandwiches can really provide a lot of joy. And lastly, the final kind of person-centered tip that I'll share here is to create a supportive environment. So talk with the person about what a supportive environment looks and feels like to them, especially early on in the condition. And really make note of this. Write it down if you can. Make a recording if you can. This will really help to ensure that over time that we're able to create an environment that best supports them. Some people like very lively environments. Some people like very calm environments. Some people like to be exposed to nature. Some people, like I said before, want to be in comfortable environments. That this can be really important to note. Some people like to have photos of people from the past. Some people love certain types of animals or certain types of topics. It can be helpful to have that around them, because that'll help to bring them some delight. Think about changes that you can do in your home that can also increase safety. It's really important to think about what potential modifications that you can bring into your home to make things safer. So, for example, if you have a lot of loose rugs, those are potential tripping hazards. So you might want to chain some of that out. Having low-lying tables can also be tripping hazards. So think about how you can make some of those adjustments. That includes also thinking about putting in railing in the home, or trying to put kind of a mat in the bath that is non-slip. Really just thinking about how many ways can we make changes to the home now that they can participate in, that can continue to keep the space feeling like home, but just a little bit safer. In creating that supportive environment, suggest those activities that they really like and really pay attention to them. And then keep favorite items where the person can easily see them, whether that's photos, jewelry, um, kind of mementos like trophies, blankets, anything that really makes them happy and brings them happy memories. I think that's a great thing to have available and very visible for them. Creating a calm and soothing atmosphere can be really nice, whether that's with having lights that you can adjust in terms of how bright they are. There are some light bulbs out there that you can actually change the color of those lights from very bright white or bluish light to kind of warmer yellowish lights. It can be a little bit more relaxing. Sometimes you can have kind of images of nature. It can be nice to have a video playing in the background of scenes of nature or scenes from someone's kind of hometown. If you have a computer and you have access to the internet, you can find videos like this on sites like youtube.com. On there, you can always search for things. So, for example, if your loved one grew up on a farm, you can always pull up images of a farm, kind of just peaceful images of cows grazing or someone farming, things that really help to create a sense of home and can calm them. And then, of course, really take care of yourself. Ask family and friends for help if you feel stressed or need a break. This is a really challenging thing to do for some of us, but it's a really important one. And I'll talk about that a little bit more in just a minute. So I'd like to now switch over to taking a look at building your own support team. You can't do a good job taking care of someone else if you don't take care of yourself. It's important for caregivers to pay attention to their own physical and emotional health. This can help you better handle the challenges of caring for someone living with dementia. And for this reason, it's important to build a support team. A support team is a group of people who can help you with care responsibilities over the course of the disease. This team can help you with many responsibilities. So, for example, they can manage medical appointments, they can provide transportation and help with grocery shopping or running errands. It's really up to you to make your own list of things that you need help with. In these types of situations, oftentimes people, if they really want to help, they'll say, what can I help with? And you may not have an answer in the moment, but sometimes it can be easier to think about, what do you need? What are the things that you need? So that when they ask, what can I help with? You can tell them, I don't know exactly what you can help me with, but these are the things that I need. It's important to understand that asking for help is not a sign of weakness. I'll say this again. So it asking for help is not a sign of weakness, because we already know that when you have help, you can be a better caregiver. Some of the benefits of having a support team include getting more done each day, staying active in your own life and taking time to care for yourself, and having people to help lower your stress. They can step in when you feel there's too much to do, or help if there's an emergency situation. I also want to note here that it's important to have a plan for an emergency. You want to think about who can help and how will they help in the case of an emergency. This plan will give you and your support team confidence if an emergency comes up. Some people like to have a sheet of paper on the refrigerator that says numbers to call in case of an emergency, where to find a bag in case of emergency that has clothing and other items to take to the hospital, for example, if that's a situation that happens. And people who've said, I want to be there in case of a big emergency, to take you to the hospital or to follow up on things or take care of the pets at home or to help with cooking or help to get the place set up when you come back. Really kind of writing that down can help to keep it very clear. Another thing that can be important for having a team is that it helps you keep up your social interactions. You have something to connect with people on. They've kind of already volunteered to be a part of that support team. So that way you can kind of keep them caught up on things that have happened during the day or that week or that month. And that'll give you an opportunity to speak with others who can help to be that support for you and really be witnesses for the journey that you're going through. So let's talk about who you should have on your team. So everyone's support team will be different. A team depends on the kinds of relationships and community in your life. Think about family, friends, neighbors, professionals, or others you trust and you can really rely on that might live with you or near you, or even far away. Your general practitioner, primary care provider, or the person's neurologist, counselor, other specialists can be a part of that. Volunteers from a local organization, members of a faith-based community, or other community members who could help you with meals or transportation can also be part of that team. As you think about these individuals, think about trust, think about reliability, think about those that know how you like to be supported and also how they know the person living with dementia might want to be supported. Um, this trusted person, the more trusted they are, you really want to hold on to them and really nurture that relationship with them. You may not need them today. You may need them later on as the disease progresses. So you may want to keep in touch with them and give them periodic updates. Um, Try as best as possible not to choose people who seem judgmental, critical, or blaming. Um, you may have some of these individuals in your life, and they just might not be a really good source for support in times of need. So maybe you don't have too many options, but really focus on those that provide support to you. Because if you bring on people into the care team that you're supporting a lot, that could actually continue to drain on your caregiving battery, where you're not only supporting the person with dementia, but this other person who's on your team. Keep in mind that your care team can also change over time as the disease progresses. You may need people earlier on to help with more complicated conversations, with managing medical appointments. But as the disease progresses, you may actually need more help with day to day things like helping with bathing and dressing, preparing meals, with running errands, with helping to manage finances or assembling tax documents, or just kind of keeping an eye on things while you're away. To get started in building your support team, think about what kind of help you need specifically. This could include giving you emotional support. And we all know those people in our lives who are really good at giving emotional support, who are really great listeners. Really hold on to those people and really focus on them for those moments. Some people may not be really great at emotional support, but they have a car and they're pretty good drivers, so they can really help with providing transportation, even picking up medications or helping with general care duties. Then talk with each of the people you'd like to have on your team. When you talk to them, be specific. Tell them exactly what help you need now and what you may need in the future. And try not to take it personally if someone isn't able to help you. You really want people on your care team who really are not only open, but willing and really feel that they have the bandwidth to help you in the moment. And always be sure to share your appreciation and thank them. People will know you value them and will be more likely to help again in the future. That might include a very simple text message that says thank you so much, a phone call, a really nice card, or even kind of treating them to a meal. And with all this said, it can be really hard or seem strange to focus on your own health when you are caring for someone else, but taking care of yourself is very important. It can help you be a better caregiver. Caregivers of people living with dementia are most likely to experience anxiety and depression than non dementia caregivers. They're also more likely to experience financial and physical difficulties. So, taking care of yourself needs to really be a priority. It's also important to recognize the signs of caregiver stress. Common symptoms might include denial. You might not want to accept or believe that the person has the disease or believe that it will get worse over time. You might experience anger. You might feel angry at or frustrated with the person living with Alzheimer's because they can't do the things that they could do before. You might experience social withdrawal. Maybe you stay away from friends and activities that used to make you feel good. Might be feeling anxious or really nervous. You might feel these feelings of anxiousness or worries about the future or just facing another day. You might be feeling down and depressed, feeling constant sadness or loss of interest, or like your spirit is broken. You might have a decrease in appetite, even. This can affect how you deal with life. You might be feeling exhausted. You might feel very tired and have trouble doing necessary daily things for yourself, like taking care of your own doctor's appointments. You might start to notice problems with sleep. You might be having worries just before you go to bed and they'll keep you up at night. You might become irritable yourself. Your moods might change, and this can cause negativity in your responses, and your actions can make it really hard when something inevitably doesn't go as planned. You can also lose some focus. It might be difficult to concentrate as you get more and more stress, and that can make it harder for you to do your usual tasks like planning things, keeping track of appointments and medications, and who you spoke to about what. and you might experience health problems. So I would just say at this point, just reflect for yourself, you know, if you have noticed any of these symptoms in yourself, or ask yourself, are you familiar with them, or if you've noticed them in others? And as you're reflecting, think about maybe specific times where you had those kind of signs of stress come up more, and times where you noticed that they were less. And maybe you notice a pattern. Maybe the situation was because you had other people there with you. Maybe it was a certain time of day that you seem to have an easier time with. Maybe it was a certain type of activity where things felt better. Or maybe it was a particular day of the week or a particular season. Paying attention to kind of the ebb and flow of their symptoms can really be helpful. Um, some things that you can do is even kind of keep a journal for yourself, or even easier, just on a calendar, kind of one of those wall calendars that you have. Keep one for yourself that's private just for you. And at the beginning of the day, you can kind of note how you're feeling. At the end of day, you can note how you're feeling. And then maybe write down a couple of thoughts about any patterns that you noticed. And that can help you understand what things may be most supportive for you and what things might not be supportive for you. Stress can lead to physical problems. So be sure to talk to your doctor if you notice the things from the previous slide, as I mentioned, or you're having any more specific physical signs like blurred vision, stomach irritation, high blood pressure, changes in your appetite, or a lot of trouble falling asleep. Now, we've talked about what stress can look like. Now, let's take a look at a few things you can do to help prevent or manage that stress. So, here's a couple of tips to keep in mind. The first is to be realistic, grieve the losses. This feeling of grief really can come on strong, it can come in waves. It's hard to predict when it comes on. Sometimes this feeling of grief comes from the loss itself, but there's also something called anticipatory grief. Anticipatory grief means grief about potential future losses, which is very real. And there's ways to manage that. It can be helpful to manage it with a therapist. One exercise that sometimes we recommended is to actually just take some time to yourself to really imagine that future, like really visualize it, even write that what that future looks like, the worst possible future. It'll make you feel a lot of distress in the moment, but it can really help to kind of put a name and really explore those feelings of potential grief that you're thinking about in the future, to really name it. And that can help you when you're speaking with others who are giving you support, to really name what are the things that are specifically giving you a lot of stress. What are the things that you're most afraid of? Because they may be able to target their support in that way. You want to focus on enjoying the positive times, especially when you have them. We'll often talk about things like, that there will be good days and there will be bad days. And the goal is really to maximize the good days as much as possible and decrease the number of bad days as much as possible, knowing that we may not have full control over when those days happen. And enjoy really good memories. It is nice to be able to look at photos and videos and other things to really remember, the times that you had that really brought a lot of joy to you. The next thing is to know what you are doing, and to know that you're doing your best. And the care that you give really does make a difference. You may feel guilty that you can't do more, especially as the person's needs start to increase over time. You may not be able to promise how the person will get their care, but you can make sure that they receive good care and are safe. As you're putting kind of plans together, as you're planning things out, as you're kind of taking care of things day to day, just know the fact that you're paying attention to your loved one, they're already in really good hands. And really bring on people from your support team to help you out, and to really be there when you need it. All these things, I think it's just important to note that you're doing your best. And sometimes your best is being patient through a situation, and sometimes your best can be managing a million things, and that can change day to day. As I mentioned before, take care of your health. Visit your doctor at least once a year or more often if you need to. Be honest and open about your diet, your exercise, and your physical and mental health. Listen to what your body tells you and really pay attention to your symptoms. It can be helpful to find relaxation tips that work for you, like breathing exercises or meditation. You'll hear more about a lot of these tips in future webinars, but think some things that you can do, like I mentioned, youtube.com has a bunch of different kind of meditation videos. There are a lot of apps that you can download on your phone around meditation. You can also ask other friends or family members if they have any recommended meditation. Some people actually just like to listen to the radio or kind of find that spot on the radio where it's white noise or kind of just garbly noise and just kind of focus on that garbliness can put you in a meditative state. Sometimes just focusing on a particular spot can bring feelings of mindfulness, whether that's kind of picking up a leaf and just really paying close attention to the leaf, or when you're having a meal, focus on all the different senses of that meal. Like if you're taking a bite of let's say a piece of chocolate, really thinking about the texture of the chocolate, the smell of the chocolate, how the chocolate feels on your tongue, the taste of that chocolate, how complex it might be, how the next chocolate looks. These things really help to kind of get you out of your body and out of your head and really help to lower your heart rate and your blood pressure. One specific breathing technique that I like to recommend is something called cyclic sighing. So, cyclic sighing is a particular type of breathing, and you may have heard of other breathing techniques. One is called box breathing, where you take a deep breath in, you hold it for 4 seconds, and breathe out for 4 seconds, and then hold it for 4 seconds, breathe in for 4 seconds. So, it's this kind of in, hold, out, hold, and that's that box breathing. Cyclic sighing is a little different. You take in a deep breath through your nose. When you kind of reach that tippy top of the breath, take in one more little breath through your nose, and then you do a slow breath out. And it's that slow breath out that really starts to lower your heart rate, can lower your blood pressure, can make your respiratory rate slow a little bit more. And there's a lot of really great research showing how it can really help to reduce stress pretty quickly, even if you just do it for about 5 minutes. If you do that kind of breathing, though, I would recommend do it seated for the first time because you don't want to get lightheaded and have a fall. Um, the next thing I recommend is taking a break. It's very, very normal to need a break from caregiving duties. No one can do it all by themselves. So it can be helpful to look into respite care, especially early, to allow time for you to rest and take care of yourself. And respite care can look different day to day. So, for example, sometimes respite can look like, enlisting the help of an adult day program or having help of a home care or home health aide. But respite can also look like little micro breaks, like when you're in the shower. Right? When you're in the shower, no one can bother you. So really focus on these micro breaks and try to build some of these in, because respite can look different day to day. And then the last tip I'll give here is to really get the help that you need. People living with Alzheimer's disease will change in terms of their symptoms over time, and their needs will change with that. They may require more care than what you can give them by yourself. So there's a lot of community resources that you can learn about and a lot of care options. And this can include home care services. It can include learning about residential care and other programs. And these options can all make a lot of these transitions a lot easier. So hopefully that helped to provide a bit of a whirlwind tour about different ways so you can kind of have a foundation for yourself as a caregiver. Future webinar sessions will go into some of these topics in a lot more detail, but hopefully that kind of gave you a nice overview. And at this time, I'd like to transition over back to David so we can go through some questions.
I was talking and I wasn't on. How about that? Okay. So imagine that. My what? Never mind. So that was expansive and wonderful, Dr. Salinas. I think it's going to take a time for myself as well as everybody who's in the audience to kind of let some of these ideas, thoughts, tips, and tools sort of settle in and digest a little bit. And there are some very good questions that showed up in the Q&A here, and I'll ask you the first one here, which was from one of our attendees, and the question was, can you talk about how vision and hearing loss affect the family member who has MCD and enjoys reading and watching TV regarding politics? And we know, we didn't talk about it today, but we know that vision and hearing loss are common co-inhabitants and might be related to even the development of Alzheimer's. But yeah,
Right.
can you share with us, what you can say about vision and hearing loss and
Yeah.
how caregivers might even, how they can react to that?
Yeah, no, great question. So sensory impairments in general are important things to pay attention to. I would say even before someone develops one of these conditions, having hearing loss, and this is kind of data that just came out in the last 10 years or so, that hearing loss actually does increase your risk of developing cognitive impairment. We're still not really sure why. It may be an early sign of changes in the brain, but it can also be a decrease in your ability to engage with the world around you. And so I think the first thing around any kind of sensory impairments is to try to find ways to address it specifically. So with hearing loss, that means going to see an audiologist or some other kind of hearing specialist that can do an evaluation and see if maybe hearing aids can be helpful. If hearing aids are helpful, finding ways to help make sure that they are using the hearing aid, that the hearing aid is placed in the right way, that the batteries are fully charged, because that can help to provide a better sense of the environment. Because without it, it can lead to some disorientation. Sometimes that means making accommodations in terms of sound. So, watching TV or conversations, people might speak a little bit louder. One of the most common forms of hearing loss as we get older is called presbycusis. But basically, what that means is kind of typical hearing loss with age. And one of the things that becomes harder and harder to listen to is high pitched sounds. And so you can always lower the register of your voice like this, and that might be a little bit easier to hear. Um, and so the accommodations like that, and most, even like for example, if you're seeing a doctor, you're at a hospital, there might be ways to accommodate. There are certain little radio kind of like headsets that can be provided, so that way they have the headphones in and they have a device that can pick up the sound and turn up the volume just for them. Be sure to mention that. Vision impairment, similarly, you want to make sure that you're seeing an eye doctor as needed. There are some kind of conditions that can be treatable that relate to the vision loss. But if it's due to the other common vision loss as we get older called presbyopia, things like glasses can potentially be helpful. And just making sure that the prescription of the glasses is kept up to date, making sure that the glasses are clean, that they're available, and that they're easy to use. Sometimes it can be helpful to have the glasses on a chain so that way they don't get lost. And then using if you have kind of labels and things around the home, making sure that the writing is large so that way they can see it. That if you want them to engage with reading materials and reading Reader's Digest as an example, this they have the large font version of Reader's Digest. But even if you're using a computer or some other kind of device that lets you read, you can always turn up the size of the font so that way it's easier to see. I think in general, the more that you create an environment where a person can engage with their senses, the less likely they are to get confused and disoriented. So I really love this question. And I think the key thing is just to really pay attention to when those changes are happening and then work with your care team to address those changes and make accommodations throughout the day.
That's a great answer, Joel. It makes me think of, and the only reason I think about this is everybody, as you've already mentioned, in the upper age brackets, so we call us seniors, we lose those high pitches, but we also have some other forms of hearing loss that go along with that.
Mm-hmm.
It's very common now to see hearing aids coming out that you can just buy over the counter. The Apple iPods, the new ones have a hearing support mechanism or something like
That's a
that.
great point. Yeah, that's right. They can do a hearing test and they can actually adjust so that way they actually function kind of like a hearing aid.
Yes, right. And I think there's two parts to that. One is that it's wonderful that access is out there, but your point about getting your hearing tested is probably more important that you find the right hearing aid. Because some of
Mm-hmm.
those hearing aids, while they're very effective and they're now allowed to be, especially over the counter, may not be the right thing. So it's just something that this is probably the best way a caregiver of somebody who has hearing loss to a significant degree and it's affecting their life can impact on that. So, and I can, at another time, I could share personal experiences. My mother went through a lot of that stuff and she had visual difficulties in the really in the middle of the disease process that made it difficult. So I can sympathize with those issues. So we have other questions. Let me see if I can catch up here to where I'm at here. Okay. Let's see. Sorry for one moment here. Okay. One of our attendees asked the question, what to look, what can I look for? Or how do I, let me see if I can say this. I want to say this just the way that she worded it. Suggestions for what to look for. How do we be more observant? She was talking about being more observant. She doesn't know what to look for and how to sort of monitor the progression of the illness, I guess. And maybe you could share us insights about that.
Yeah, the things to look for are different brain functions, and that's really boils down to how the person is functioning in their day to day. So, we talk about different brain functions like memory is the most common one that we associate with these conditions, like repeating yourself in conversations, forgetting details that are really important, um, forgetting names of people that are very familiar, forgetting kind of where they place things, things like leaving the stove on, leaving the keys are things that can happen. But more than anything, it's these forgetting, like, for example, that this morning you had a family member visit, or being told a piece of information and then immediately after forgetting that it ever happened. That relates to memory. Usually it's short-term memory that gets affected most. Things like long-term memory, like where you grew up, those things are usually pretty intact. So those are less likely to be the case. Um, Another area of functioning is what we call attention or executive functioning. So that's really about being able to focus on things, being able to do judgment, planning, organization. So having a hard time doing day-to-day tasks, having a hard time learning new things, learning new skills or devices. For example, someone who used to be really good at using computer might suddenly have a harder and harder time using the computer. Or someone who used to have an easy time kind of getting around the house and kind of doing laundry or doing the dishes may have a harder time. Another area is visual spatial functioning, but basically to say like getting lost in typically a place that you typically be familiar with. So let's say you're in your neighborhood that you've been there for your whole life, and now you're having a harder time navigating it, not really sure where to make a turn or where something's located. Speech and language is another area. So having a harder time finding the right word, having a harder time understanding what people are saying despite being able to hear them okay, and not being as fluent as used to. Something that we see in people who are very eloquent, have a pretty big vocabulary, like writers or people that were teachers and had other professions. They might not have an easy as time as they used to reach much more complex words, and suddenly the vocabulary is becoming more and more simple. Um, and then another area that I think is important is social interactions. So having a harder time navigating social interactions, showing less empathy than they would, not really kind of reading the room, becoming more disinhibited or impulsive. These are more behavioral changes, or really just a big personality change. Like, let's say they were always very happy go lucky, and suddenly they're very irritable and kind of kept to themselves. Or the opposite. And they really just big changes in who they usually were can be a sign to look for. And more than anything, it's not just do these things happen every once in a while? But we're really paying attention to, is there a consistent pattern of decline of these things happening more and more often over the course of many months to a couple of years?
Another good answer there. Thank you. Thank you, Joel. I just want to let everybody know that Murray has been putting in references or links to other sites that might help answer some of these questions in particular. They're in the chat, and I understand that there are some or maybe many of you that aren't able to access the chat, and we'll be sure that send those out separately also when the emails come around about accessing the webinar. The questions keep coming here, so let's move on. We've got one of our attendees is having trouble with their dad with hallucinations, especially waking up at night with him. They've tried sleep meds with his doctors, but they were wondering what you can recommend when this happens in the middle of the night when he is with a caregiver.
Yeah.
Difficult problem.
Yeah. So there's two things, well, three things that'll touch on there. The first is things happening in the evening. So this is something called sundowning. You may have heard this term before, but essentially for people who are affected by these conditions, especially as the disease advances, as the day goes on, they might get more tired, and they may also become just much more prone to becoming confused and agitated in the evening. And that can relate to just being tired and having a hard time regulating things and paying attention to things. It can also involve that things are just darker and it's harder to navigate and can lead to more confusion. But sundowning is something that can happen. The other point about kind of visual hallucinations, and I'll kind of lump in here sleep, is that these activities that can happen at night, certainly can disrupt regular sleep wake cycles. So you may find your loved one falling asleep during the day, which then makes it harder to sleep in the evening. And in the evening, just because things may be darker, the brain is much more prone to generate hallucinations. So that might be a part of it. But oftentimes, medications can be helpful for hallucinations. A key question is whether the hallucinations, these visual hallucinations, are distressing. Are they scary? Are they really disorienting hallucinations? Because if they are, that might mean that it's worth starting a medication. If the hallucination happened and they're pretty comfortable and it's not causing anybody any problem, then sometimes it doesn't need to be medicated. And the reason why I mention that is that the medications that we prescribe for these hallucinations are kind of strong medications. They usually fall into the class of medication called antipsychotics. And when we do start antipsychotics, it's really to improve quality of life by reducing the intensity or the frequency of these visual hallucinations. Some of these medications are good during the day, and some are better for nighttime because they can also kind of be sedating or make a person drowsy. It's an important thing to talk to your doctor or a specialist about kind of the medication options, because sometimes the medications can interact with other medications, and they can also come with their own sets of complications. But oftentimes what we'll do is start with a low dose and slowly kind of go up on the medication. It's also why it's so important to know the cause of the dementia or the cognitive issue, because some of these medications can actually cause really significant kind of reactions, the really significant negative reactions. And so just like, with cancer, which is another umbrella term where you want to know the type of cancer so you know how to best treat the cancer, it's true with these conditions, these dementias, is to understand the type of dementia so you know what treatments are usually best for what situations. But I think a good place to start, if anything, in terms of non-medications, you can create a routine that can include kind of going to bed at the same time and waking up at the same time. Things like melatonin, especially a lower dose of melatonin at that same time every night. Usually I recommend 12 hours before you want to wake up. So like if you want to wake up at 8 a.m., take it at 8 p.m. every night. And then creating a routine around kind of dimming the lights, turning off any distractions, getting into bed, getting comfortable, playing soft music, anything that can help with creating a more kind of inviting sleep environment can help there.
Okay, let's see. We have more.
Mm-hmm.
One of our attendees talks about her dad always enjoyed reading Bible, devotional books, even medical books about natural remedies, etc.
Mm-hmm.
And he's pretty much stopped reading. She encourages him to read something or for them to read together, and he can read but doesn't seem to enjoy it. Is this common for people with dementia type diseases? Is it a possible sign that he doesn't comprehend what he is reading?
Yes, it is common where it can be the case that as the disease progresses, it can be harder to read. It can be true for a number of different reasons. If the condition is affecting vision or kind of visual spatial function, like I talked about before, it can be hard to see the writing itself. Sometimes it's issues with attention, just being able to focus, and sometimes it's related to language. And sometimes it's just like memory, being able to remember what you just read. And so that can make it more challenging. Um, there are ways to make accommodations in those situations. Sometimes it means switching over to easier topics. Sometimes it can involve bigger text, things with simpler ideas. But another thing that I'll often recommend, especially when people start to have difficulty with vision specifically, is to kind of move over to audiobooks. There's a lot of audiobooks out there that you can find that might be a good fit, whether it's fiction or nonfiction. You can also find kind of audiobooks for free through like YouTube, for example. Like I keep on going back to YouTube, but I feel like it's a lot of resources on there. Um, but you can also read the book to them or can read a passage to them. Some people will also who can still do some reading but need a little bit of help of kind of where to keep track of what they're reading. If it's something that's like printed out, for example, slightly bigger font, they can have like a highlighter and then just highlight as they're reading, so that way they keep track of where their place was as they were reading.
Yeah, just to expand on that idea just a little bit, or at least as a reference, I recently discovered that Spotify has a lot of audiobooks for free. Uh,
Right.
and it has a large store of that, of course. And you can also listen to music or podcasts if you're one of those podcast types of folks. But so anyway, that's just a reference that you might consider if you're looking at listening as an alternative to actively reading. I have two people that have asked almost the identical question. I'll share them with you what they are. The one
Right.
is, how do I convince my loved one to see a doctor to get a diagnosis? And
Mm.
very close to that is, how do you deal with a loved one who is in denial about their cognitive abilities, vision, etc.? They will not get evaluated, but are showing all the classic signs.
Yeah, such a hard issue to tackle. My heart goes out to you because it is a hard one, and it's also extremely common. It's a situation that we often see in the clinic, um, when people do make it into the clinic. So it certainly can cause a lot of distress, a lot of strife, a lot of arguments and discussions. I think there's I think two things that I'll highlight here. One is that it can help to realize that the condition itself may actually make it very hard to notice kind of the symptoms that are going on. The term that we use here is insight. We'll have a lack of insight. But essentially, the condition itself can make it very hard for the person to know that they're having issues. For example, if they have difficulty with memory, they may not remember the lapses that they're having. And so they can swear up and down that everything is fine because they're just not recalling what's happening. And in those situations, it can be helpful to start to kind of gather instances when it happens. And oftentimes, people can become very defensive because it relates to identity. Identity is a very sensitive topic. Independence is a very sensitive topic. People often have really significant fears around these types of conditions. In particular, are common when people have a fear of being institutionalized or being put into a nursing home or a memory care unit. And so finding ways to normalize the conversations around this, um, really kind of keeping track of how often things are happening can help to kind of show, rather than saying a big judgment like you are having concerning signs or I'm worried that you have dementia, really having like a sit down and just saying, I've noticed a couple of things that have been going on, and maybe you disagree with me on some of them, but maybe we can kind of go through some of them and just go through kind of what I've noticed, and then say, on this day this big thing happened, and on this day this happened, and really focusing on the facts or the behaviors that happened, can help to provide a little bit of insight, but also sharing your own feelings about the situation and how it's affecting you and the people around you, especially if there's safety issues. And you can always work with the clinical team. This is something that we do at Isaac, is that sometimes what we'll do is we'll create kind of split visits, so that way it's really focused on brain health, right? We want to make sure that we're respecting everyone's autonomy and their dignity in the situation. And so we can really just say, maybe there is nothing going on, but let's kind of work together to really find out if that's the case. And then having a split visit where both people come into the room, and then there's a moment for each person to have private time with the doctor or the provider, so that way the patient can give their perspective without fear of judgment or someone kind of giving objections. And then the caregiver, the care partner, can then give their perspective on what's going on without fear of the other person becoming really agitated or angry about what's going on, and then bring everybody together afterward to kind of bring together a big picture. But I would say if you're able to kind of focus more on kind of the facts of what's going on and slowly work with them, that might help to bring allegiance to it. And sometimes it might not be you, the right person, to bring it up. Maybe there's somebody in their life that they really trust a lot, like their son, daughter, brother, sister, cousin, parent, and having that person on your team to kind of work with them on it, and doing kind of the thing of saying, let's check, even if there is nothing, it's good to just know.
That's all good advice. And we have another couple of questions here that this one is particularly interesting because I've had some personal
Mhm.
experience with this one. And after you give your answer, I'm setting you up for trouble here, I think. I
Oh
hope
no.
not. After you give your answer. And okay, I'll give you the question. Do
Mhm.
you recommend getting your genes tested And the attendee says, my dad, who is 78, has both copies of the APOE4 gene, and he has dementia. The attendee is almost 50. Is it worth it to know earlier? And can supplements like choline help?
Yeah, I will. I'll focus on the genetics question first, and I'll say that for that, I'll probably give an unsatisfying answer, which is like a typical kind of like researcher or scientist type of answer, which is that it depends, whether it's reasonable to get genetic testing. In general, if it's important to think about what the purpose behind the genetic testing is. So if the purpose behind the genetic testing is to understand your own risk, then that's something to kind of really present to your doctor, physician, whoever's caring for you. In general, family members that you have that develop conditions like Alzheimer's disease, that alone does increase your risk compared to the general population that you may develop on these conditions down the road. It's not a guarantee that you'll develop it, but it does potentially increase your risk. That said, when people develop these conditions after age 65, we call that late onset. Late onset kind of dementia, particularly onset Alzheimer's disease, the chances are much higher that it's due to what we call sporadic causes. So really, it's non-inherited or non-genetic causes. It's more the age that's driving it. There might be a lot of other factors and some very small genetic things going on, but never huge enough that really says, we really should be doing genetic testing. The flip side of that is if people in your family, like many people in your family, are developing this condition under age 65, let's say in their 40s or 50s, we call that early onset, and there may be an increase in risk with a rare genetic mutation, especially if many people are having this condition. So that'd be something to talk to your doctor about specifically, so that way they can kind of map out kind of the inheritance pattern to see whether genetic testing is useful. Generally, this ApoE genotyping can potentially be useful. It is available through commercial genetic testing like 23andMe or Ancestry.com and others. Doctors can also order it. It may not always be covered by insurance. It's not actually an FDA kind of approved thing, just because there's so much variation across each individual test. So every lab has their own way of doing the genetic testing. But generally, if you do decide to find out your ApoE status, it's also helpful before you do the testing and before you even know the results to understand what different test results mean. So there's 3 different types of ApoE. There's E2, E3, and E4, and everybody gets 2 copies, one from your mom, one from your dad. If having an ApoE2, an E2 lowers your risk potentially. E3 is kind of neutral risk. And what we're really paying attention to is E4. So if you have 1 or 2 copies of E4, that does potentially increase your risk, but it increases your risk compared to the general population that might not have that genetic risk factor. And it's an increase in risk as you get much older. So as you get over 65, 70, 80, and get even to your 90s, then your risk increases more so that way. And there's other implications related to that with the new medication. So that's when it becomes even more important to do the genetic testing. But we don't always check these things. If you have a specific reason to check it, just make sure that you're pretty educated and informed about what the results mean. I would hate for someone to get an ApoE4 or kind of 2 copies of ApoE4 and then believe that they have Alzheimer's disease, or that they're definitely going to develop these conditions. These are really generally risk factors, and all of the protective lifestyle things that you can do can actually still offset some of that risk.
I'm going to step in a little bit here and just give a little of my personal experience, whether this is the right or the wrong answer or not. I don't know. But my mother had Alzheimer's disease and passed away a number of years ago. Mm-hmm. And as I actually was retiring not too long after that, and recognized that my risk for Alzheimer's disease would be higher than most males, say at age 65 and beyond, right? So not knowing exactly what that meant, and the question that I asked myself was, would I want to know with this information, or what would I do with this information? So I used the information, or I was going to use the information, and I did, I think, to recognize that before the disease has gotten into the at least the active stages, and maybe even during the mild cognitive dysplasia stage, there are lifestyle things that that we can do to at least lower our risk. Whether or not it changes the progression of the disease is entirely unproven. But so that's the way I thought about it. So, what I wanted to do was have the lowest risk I could possibly have, I guess. So I got the gene testing. I discovered I do have one of the E4s. And because of that, it was okay. Well, here I am, 65, going on 66. It's a little late to be worried about this, perhaps, but maybe it's not. So I basically use it as a motivator to do whatever I could to lower risk. I was already a pretty active exerciser, but my eating habits were particularly poor. So along those lines, and I had some other issues that could be helped with better eating habits too, high blood pressure and things like that. So I use it as a motivator. And I have two younger sisters who are not sure what to do with that information either, and are not going through the testing right now. But that's kind of the way I approached it, and I hope that's helpful to anybody else who out there is looking at what are you gonna do with the information? It doesn't mean you're gonna get it, the disease. It doesn't. I don't expect to have the disease just because I have one gene. Having two genes is a much more dramatic risk, but you don't have to have it even if you have both genes, is my, is what
Correct.
I've been
That's
able to
right.
understand from that. So that's really the end of that question. And we got more questions. I better be quiet and move on here. Okay. What about when your loved one, not a spouse, sexually acts out? My parent is alienating friends, sending inappropriate texts, etc. That's an
Mm.
interesting question. I'm sure you
Yeah,
have an
that
answer. I hope that's a tough
yeah.
one. Yeah.
Yeah, no, I mean, these kinds of behaviors can happen with the disease, and I think it's important people know you the way that these diseases manifest vary wildly from person to person. So just because one person has it doesn't mean that your loved one will have it, but the sexually inappropriate behavior can happen. Um, some of the things that we figure through in clinic is potentially thinking about what kinds of medications may be helpful to reduce some of that. There are some very basic medications that help with mood and with behavior regulation. These what they're called SSRIs or SRIs. They're essentially medications that are often used for antidepressants and for anti-anxiety. And those medications alone can actually, over the course of a couple of weeks to a couple of months, actually lower the sexual drive as well. So that might actually help with those types of behaviors. It can also help with some of that impulsivity or disinhibition. If the impulsivity or disinhibition is very, very high, and there can lead to harm to self or other, then we start to talk about those heavier medications. But some non kind of medication ways to approach that might be to kind of maybe have some restrictions around kind of communication or the times for use of the device, or to only use things under supervision. Certainly, that might cause some strife between the two, but that might help with kind of reducing the likelihood of harming others unintentionally. Um, an example of kind of ways to kind of have some restrictions that help to kind of control the environment, for example, sometimes people can become very disinhibited and do a lot of overeating, like very compulsive eating, and it can happen at all hours, especially kind of at night. This midnight snacking can be a real problem for people, and so sometimes it can be helpful to actually put a lock on the refrigerator, or dangerous items in the home like a firearm. We talk about this a lot. Is to make sure that it's locked, and that's that the caregiver is someone who's kind of supervising or providing care can actually have access to that key to avoid any potential danger. That includes car keys as well. If someone really, it's not safe for them to drive, but they really insist on driving, it can be helpful to have those keys behind another lock, or have them kind of stored somewhere that they're not accessible.
All right. Well, Joel, we've got one more question here, and I think we're gonna close out. And either Corey or if you could start to show the resource slide for the
Yeah.
I guess the next one would be for the Alzheimer's Association, and then put the one up for Isaac Health a little, in just a few minutes also here. But the last question is from an attendee who says, Her mom has vascular dementia. She doesn't
Mhm.
talk much, wants to stay in bed all day. Is this normal? Is there anything I can do or talk to her neurologist or primary care provider about?
Yeah, yeah. So what you're describing, this lack of motivation, the lack of interest, and like not wanting to get up and go, that there's a specific term that we use for this called apathy, and it is a symptom that can happen in these conditions. It's actually quite common in people who have vascular dementia because parts of the brain that get injured in this condition, especially when it's due to kind of changes in the small blood vessels in the brain, affects the frontal part of the brain, which is really like the captain of the ship of the brain. And so that gets in the way of motivation and kind of really planning things out. So a couple of things that can help with apathy. So non-medication things can really focus on the things that really do inspire motivation or inspiration or get them active. So for example, um, maybe they're not really interested in eating or kind of getting dressed, but maybe things like a particular type of show or movie gets their attention, or particular type of music or a genre of music gets their attention, or having someone over at the house who really they get along really well with and kind of lifts their energy up can be good to have around. You can also do things like and this is also comes along with regulating sleep wake cycles, like during the daytime, open windows, play music, open the doors, really kind of keep them active in different types of activities. It can also help to kind of start low, like a little bit, like do one step to the next thing to really kind of do successive steps to get them to do the activity. Um, but there are medications that can help with apathy. Sometimes these are things they're called stimulants, things like methylphenidate. There are other types of medications that can be used. Sometimes the antidepressants themselves can be used in situations like this, but there are some medications options, and you just want to talk about that with your doctor or specialist in these conditions. It's something that we will have to manage at Isaac. We'll try to figure out these different symptoms and then try to figure out what's the best option so that way they can kind of continue to go about their day. And these kind of symptoms of apathy can change over time and fluctuate, where some days or sometimes it's worse and sometimes it's actually better.
All right. That's a this has been a wonderful talk, Joel. I really appreciate your time. I know the audience does. We've had some outstanding questions. And I think it's just about time to close us off here. On your screen, everyone, there's some resources there that we publish for the Alzheimer's Association, including their helpline. There's some opportunities to look for local resources, which is probably a very useful thing for getting some help and finding out who can be an assistant in your and finding support groups and things like that. We've put this in the chat line, and Joel, if before I and actually right now, why don't you can you put up the slide from Isaac Health
Yeah,
and their
absolutely.
resources? There you go. But in the chat, and I hope everybody gets it. If they don't have it now, they'll have it in the when we send out the reference to or the link to getting to the webinar. So the webinar has been recorded. Everybody who's signed up for this will get an email after the conference is over that gives them directions on how to get back to the webinar and how to get into the chat room. There's plenty of references in the chat that Corey has downloaded for everyone to use for some specific questions in there. So I encourage you all to get that. Joel, Dr. Salinas has put on how to contact Isaac Health, and I would encourage you just to go to their website and look through that in fairly extensive detail because there are a number of helpful resources that you can access right from your home. And that is about the end of what I have for today. So thank you all for attending. We have the next one coming up next week, a week from today, same time, same channel. And it's on supporting independence. It'll expand on some of the things we talked about today with some new information. Let's see, Dr. What? Oh yeah, Dr. Debbie Prouty will be giving the discussion then, and fortunately or unfortunately, I will be your host again next week. So I look forward to having you join us again next week. And thank you for your attendance.
Thank you all.